because had started it in three before that we have three small sessions, okay, and this is the fourth one. And our basic discussion was revolving around the basic basic mechanism by which electrolytes or water move from one compartment to the other compartment, and how that thing is being maintained. Okay, so just as a recap, I will just share few of the things, and then we will go to we will move forward. Like we are discussing about sodium, and we discuss about its distribution in ECF and ICF. Okay, and sodium is maintaining the osmolarity. Okay, and there is a concept of tonicity, by which if you are moving like any condition like this occur, either the cell ECF, sorry, either the ICF volume will increase or it will decrease. Okay, so this will have serious consequences, especially in brain. Okay, so for maintenance, we have ADH, we have aldosterone. Okay, and we have this ADH also through this thirst mechanism. Okay, then there are some. Am I audible to you? Can you hear me? Am I audible to you? Please just respond. Okay, so then there is concept of ANP, BNP, and there is a concept of volume, because the result of sodium will change the volume status between ICF, ACF. It will be affecting the tonicity. Okay, it will affect the blood circulatory volume, and it will it somehow affect also blood pressure. And so there is a strict control. So there is control by this sympathetic outflow through this baroreceptor control. Okay, this is stretch receptor. So this is resulting in, so if we have any problem in this mechanism, it will result in either high sodium or low sodium. So whenever we are trying to understand, we have to understand two things. Either it is for hyponatremia or hypernatremia. The basic concept is that whether total sodium is increased or not, and the volume status is increased or decreased. Okay, and also this one, what is effect on the osmolality. Okay, so today we will just continue from where we stopped yesterday. I told you that I will just try to, by the way, this is actually a module. I'm not sure whether some new one has arrived on the website or not, but it is from the source of European Society of Intensive Care Medicine, and they have created you can sort of a patient-centered discussion in the way, problem-based, and it is part of the curriculum which they offer for this European Diploma in Intensive Care. Okay, this is not European Diploma in Anesthesia and ICU. This is European Diploma in Intensive Care. Okay, so I just find this source nice, so I just will go through it. A number of things are being rapid, there will be a lot of repetition, but because this topic even needs more attention than when usually we give, and if you want to be a good anesthetist, you should have a very intensivist as well as intensivist. You should have a very good concept of this fluid, electrolyte, acid base balance, because they are interlinked. So if you just try to grab one part of it, you will not be able to swallow it. And even if you say that exam point of view, forget about exam point of view. This is a matter of dealing with lives of the patients. Okay. So I will just try to cover this source, and then we will just have a look on some of the other things related to sodium, of course. Okay. So yes, another thing is that whatever disorder occurs between the sodium, another thing important is how fast it develops and how fast you treat it. Because if you try to overcorrect it, try to be very fast, there will be problem. Either if you are correcting hyponatremia and you are putting hypertonic saline, it can cause serious sequelae. Similarly, if you are treating hyponatremia and you are trying to be very fast, it will result in cerebral edema. The other one will cause central myelinosis, pontine myelinosis. Okay, so this is very important. The symptoms, in some time it is like they mimic. So sometimes it is difficult to identify only on the clinical features, because both will result in neurological symptoms, confusion, lethargy, maybe some neurological this fits can occur. So both of them, the hyponatremia will have hypoactivity more, and hypernatremia will have hyperactivity. Okay. So convulsions, stupor, and then similarly, this we are all familiar with it. TURP. By the way, I will just to make you people interested. What is gynecological TURP? Have you heard? Any one of you heard about this terminology? Gynecological TURP. Yes. Tayyab? Moazama?
Sir, oxytocin.
No, 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 no.
Sir, laparoscopic gynecological procedures में TRP,
Yes.
hyponatremia can occur, fluid overload can occur.
Yes. Actually, they are doing this through vaginal route. They are doing the myomectomy, and in that they are injecting a lot of fluid, and it is also being absorbed in almost a similar way as occur in TURP. So that is resulting in the same hypotonia, hypotonic state as occurs in TURP. So this is one of the thing you should be aware of, because in coming days it will be done more and more. Okay. And then you have to rule out some predisposing factors like hypothyroidism, cirrhosis, chronic heart failure. Okay. And syndromes, the conditions or medications which are result in SIADH. Okay. So any problem in hypothalamus, any problem in adrenal, any problem in like the mechanisms which are controlling the body volume, that will be related to heart, that will be related to liver, that will be related to kidney. So all of them will affect sodium. Okay. And another thing you should be thinking, just to brainstorm your mind, that it will be occurring in physiologically in some patients, like extremes of age, neonates and elderly patients. Okay. So who will lose the concentrating ability of kidneys, so they will also result in hyponatremia. Okay. So they are not concentrating ability, retention capability of sodium, so they are losing sodium. Okay. So they are using this glycine, sorbitol, mannitol. Okay. So it is being absorbed and causing the not only it will result in hyponatremia, it will cause signs of volume overload as well. Okay. And this is question related to TURP, but here they have mentioned here that duration of the surgery, height. Okay. It is very important, and how much tissue they are resecting. Okay. So that will be resulting in, usually they are saying that even up to 3 liters can be so dilution reduction in the plasma sodium concentration that may fall below 100 even. Okay. So usually the symptoms will occur after 120 usually. Okay. So then if the patient is stuporous or convulsed, if they are asking you this question, don't forget that airway breathing circulation should be your first priority. Never forget, because when they ask you this question, you start your answer with, sir, we will give hypertonic saline. Okay, so this is not the answer. If the patient is not maintaining the conscious level or not maintaining the airway, the answer should be starting from airway breathing. Even in the MCQ, they can put the same thing. So if they are asking you what will be the first thing to do, so you should be answering in a similar fashion. Okay, so among the laboratory investigations for all these will be, one of them is plasma osmolality, urine osmolality, and urinary levels. Okay, so this will be telling you a lot of information. So plasma is key to categorizing the etiology of hyponatremia. Okay, the urine osmolality, because what will happen that if urine osmolality is more, okay, so it means like more of the water is being absorbed, okay, and the concentration is becoming more. So similarly, if urine osmolality is less, so in those patients with hypotonic hyponatremia, the urine osmolality can be used to distinguish between impaired water excretion, which is present in almost all cases, indicated by a high urine osmolality, okay, and primary polydipsia, in which water excretion is normal, but intake is so high that exceeds the excretory capacity despite low urine osmolality. Okay, so in that condition, urine osmolality will be low, but actually you are, because of excess water, the urine osmolality is less because you have taken a lot of water. Okay, so then osmolar gap, it is from because of anion gap, it is because of unmeasured osmoles in plasma like mannitol and alcohols. Okay, so this is also related to SIADH, this hyperuricemia, and I was just reading that in pregnancy, there is some hormone, I forgot the name, there is some excess metabolism of ADH occurs. Okay, so so it is it will be leading to diuresis, because then when there will be less ADH, then it will be causing more water loss. Okay, so this came into my mind. So initial water retention, the initial water retention and volume expansion in the SIDH leads to hypouricemia, another frequent finding that is the opposite of typically seen with the volume depletion, in which there is increase in serum uric acid, okay, and increase uric acid excretion. The only exception to this rule is that in patients with cerebral salt wasting, despite intravascular volume depletion, the serum uric acid levels stay low. This is something new for me as well. I didn't know about it. Okay, so plasma uric acid levels will also be telling you that if the initial water retention and volume expansion leads to hypouricemia, as in SIADH, which otherwise in cerebral salt wasting syndrome there is hyponatremia, but this one. What is it? Usually, whenever there is volume depletion, uric acid should go up. Okay, so this is the what it was something new for me. I just read it today. So confirm normal renal, adrenal, thyroid function, because they will all result in hyponatremia. Okay, so these are some causes of SIADH we discussed before. Some of the drugs. So whenever you are dealing with the patient, you should, that's why the importance of medications are always very important, because there will be some medication which will result in electrolyte imbalance. Okay. So they have just put the note, key to the determination of etiology of hyponatremia is the measurement of plasma osmolality and assessment of the effective total body water volume. Okay. So that's what will occur when hypotonic hyponatremia. This is the commonest type, in which both water and salts are lost. Okay, so there is decrease in tonicity, and there is decreased sodium level. Patient can have either a decreased intravascular volume with or without edema, or a normal intravascular volume. Congestive heart failure, cirrhosis, nephrotic syndrome cause an edematous status, in which there is increased intravascular volume, and actually this is going in the third spacing. Okay, there will be usually edema, but edema is not mandatory. Still, they can have hypotension and low effective circulatory volume because of failure as well, because their circulation is not able to handle the extra volume. Okay. The two major conditions causing euvolemic hyponatremia are Siadh and primary psychogenic polydipsia. These two conditions can be readily differentiated. Actually, an Siadh picture can be of euvolemia and it can be of hypervolemia. There may be increased volume, and that's what we discussed before. And Mozdama, you were asking this question. So this is an error of measurement. This is not the correct hyponatremia, and it is occurring in the labs because of hyperlipids or hyperproteins. Okay, so hypertonic hyponatremia occurs due to hyperglycemia or mannitol. It is initially taking the more volume. Okay, and because they are itself osmotically active, so they are causing the hypertonicity, and then they are diluting it as well. So this sodium levels are coming low, but actually tonicity is more. Okay, and then they will cause diuresis. So mannitol administration will initially cause increased volume, and then when the excess urine comes, then the other stage will come. Okay, so how do you correct roughly the measured plasma sodium for hyperglycemia? So this is also because usually, actually, by the way, because in Saudi Arabia, I'm not working in ICU. So this is also one of the reason, because in OR, usually we are not treating it. So the things which you don't do slips from your mind more. So anyone who has who wants to participate, please just raise the hand. Okay, because this is it is better to have an interactive discussion. Okay, they make ask you that for every 5.5 millimole per liter or 100 milligram per dl, because this will be multiplied by 18. Okay, so in plasma glucose over the normal levels will decrease 1.6 millimole per liter. Okay, or it's the same. Or for every 3.5 millimole, 62 milligram, like when there is hyperglycemia, there is decrease in sodium level, the measured one. Okay, so so that's what they are trying to tell you, that for every around, you can say for every 60, 1 millimole will decrease. Okay, so another what they have, the formula for correcting the sodium for plasma glucose level. This is how they have put this formula. Measured sodium plus blood glucose level divided by 3, or measured divided by 6. If you are calculating in milligram per dl, you will divide by 62. Okay. Actually, they have put these questions, and they have put the answers at the end. These questions, you will at the end of this document, you will find the answers. This question: calculate the actual sodium concentration of all your patients with serum glucose more than 16, more than 300, using the correction formula until you reach familiarity with this, using this formula. Okay, so you can use this information to correct your see the correct levels, because if the blood sugar is high, there the level you have to adjust. Okay, so how this occurs, yesterday I told you that if you are putting hypotonic fluid in extracellular fluid, like in blood, that extra water will go inside the cell to maintain the tonicity, because water can freely pass through the cell membrane. So it will cause brain swelling, as they have told. Brain swelling occurs due to fluid shift into the cells. However, the degree of brain swelling and therefore the likelihood of neurological symptoms are much less with chronic hyponatremia, because there are adaptive mechanisms. How they are adapting? Extracellular fluid movement out of the brain into the CSF due to increase in interstitial hydrostatic pressure due to the initial cerebral edema. So it is increasing the hydrostatic pressure, so more CSF it is going towards that direction, and loss of solutes from the brain cells leading to osmotic movement of water back out of the cells. This is initially mediated by extrusion of intracellular sodium and potassium. Subsequently, over the next few days, loss of organic solutes occur, thereby restoring brain size. So like when sodium levels they are readjusted and water will go out. So this is, in simple words, maybe nobody will be asking you, but usually compensatory mechanisms occur, and this will be optimized. Okay. So what is the mechanism of injury in osmotic demyelination syndrome? Okay. Severe hyponatremia, if acute in onset, leads to brain swelling due to osmotic movement of waters into the brain cell and potentially cause reversible neurological damage and death. The brain tries to adapt by mobilizing intracellular water. You know, if anyone don't understand anything, just raise the hand. Okay. So the brain tries to adapt by mobilizing intracellular water by extruding sodium and potassium salts and certain organic solutes. They are pulling them out, thereby lowering the brain volume towards normal. In this setting, in which the increased brain volume has returned towards normal, rapid correction of severe hyponatremia can lead to the development of neurological disorder called central pontine myelinosis or osmotic dive. Because if you are correcting it fast, then the water will come out of the cells and suddenly will cause this condition. The symptoms of osmotic demyelination includes dysphagia, dysarthria, quadripresis, weakness, lethargy, seizures, and coma. Most of these symptoms are irreversible or only partially reversible. This order has been associated with the rate of rise of sodium concentration as more than 12. Oh, as little as even up to, because usually we are correcting up to 6 to 8 usually. Okay, so if you are even over correcting it even slightly, it can cause this. But the rate of correction is usually no more than 10 to 12. You will find this statement in different books, but usually it is less than 10. Okay. Osmotic demyelination syndrome is associated with alcoholism and middle age, and although more common in male, it is also recognized in pre-menopausal women and in pediatric population. Okay. So clinical management, how will you do it? The goal of therapy is not to correct the sodium more than 2 millimole per liter per hour for the initial 6 hours, but not, just a second, should not exceed 10 to 12 millimole per day. Okay. And patients with asymptomatic hyponatremia, it should not be more than 0.5 millimole per liter per hour. So, and you are gradually correcting it, and you are reassessing the clinical situation. Okay. You are also trying to treat the cause in hyponatremic patients who are hypovolemic with hemodynamic compromise. Correction of volume depletion by normal saline resuscitation is a prerequisite. Okay, so you have to correct it with normal saline. And since both intravascular volume and plasma osmolality regulate ADH secretion, so it will be necessary. So the initial outcome, however, is usually favorable if you correct it nicely. So now a few words about hypernatremia. Okay, usually hypernatremia, if occurs you know, in it will be either with high volume, or it will be with isovolemia, euvolemia, or it will be with less volume. Okay, so what may be the probable cause of low volume? Yes, nobody is speaking out. Tayyab, what may be the reason of hypovolemic hyponatremia?
Sir,
Diabetic
hypovolemic hyponatremia.
I'm sorry.
Sorry, sir.
This diabetes insipidus, you see, a lot of volume is lost because free water is lost. So that will be resulting in hypovolemia and resulting in hyponatremia. Okay, the cause of hyponatremia is usually evident from the history, and in this case, if there is the problem related to ADH, usually the patient will be volume depleted. Okay, if for example in what happens in vomiting, when there is vomiting,
There is hyponatremia, sir.
there may be hyponatremia. If there is more water loss, okay, even in diarrhea, if you have more water loss, there may be if the patient become dehydrated, then may be in the blood values, it will be hypernatremia. Okay, so it can happen in that condition as well. So whenever we are calculating it, we are like, for example, if it is here, they have for 165, so 25 will be the difference, and 25 by 140 multiplied by 0.6 is the fixed factor, and the body weight, so it will be around 7.5 liter, and that's how you will calculate the total water deficit in this condition. Okay, so in the setting of decree, both hypernatremia indicates relative water depletion and can occur with increase or total body sodium. In the setting of decreased total body sodium, both sodium and water have usually been lost, but water loss exceeds sodium losses, as I told you. Okay, leading to hypernatremia. This can be a result of renal losses. Okay, diabetes insipidus, or loop diuretic, or extra renal, as I told you, diarrhea and vomiting. Okay, so this may result, usually we think that it will be hyponatremia, but actually it can cause hypernatremia as well. There is no fixed answer to this question. It will be depending on the scenario. It can occur in both forms. So only you can get it by the ABGs. What is a clear picture? Okay. Hypernatremia with increased total body sodium is less common, and usually where you are putting the hypertonic saline or this sodium bicarb. Okay, that's why actually I tell you something, that in ICU, this is the most wrongly administered medication. They are just trying to correct the numbers, and in that you will correct the acidosis, you will be very happy, I have corrected the ABGs, and then you will find that the sodium has jumped to 170. So remember one thing, that indication of sodium bicarb is not as we are using. Majority of people are using in a wrong way. Okay, so loss of relatively salt-free water can lead to hyponatremia with normal total body sodium. Okay, loss of relatively salt-free water, only free water is going, so that will be resulting in not net result in decrease. So total body sodium will be normal. However, yes, Tayyab.
I want to ask at which pH we should give sodium bicarb?
Less than 7.1.
Less than 7.1. In one book of family medicine, I read that sodium bicarb should be given in DK when pH is 6.9.
6.9 is not sustainable to life, I think. 6.9 is very low pH.
Sir, 7.1 were old, I think, guidelines. This was latest, maybe 4 or 5 years ago.
Okay. I told you that because of lack of work in ICU, I am away from managing these patients usually. So that is
Okay,
I
sir.
cannot comment about it. Usually you can say that you should not give before less than 7.1. Okay, like
Okay, sir.
because of course it's at 6.9, you will definitely give it. So that's what I'm endorsing, that you should not use bica without any solid reason. If the patient is in acid acidosis because of lack of circulation, if you don't correct the circulation, you don't correct the hypotension, you are so that will only by giving bicarb you will not get anything. So that is the concept. The reading may be vary, maybe it is possible that the guideline they have put it to 6.9, but usually in majority of the books you will find 7.5, 7.1 up till now, whatever I recall, because of course I'm not reading these. Even I have never read this, because I was preparing for this diploma, I couldn't pass that diploma. And after that, because I'm not working, if I were working in ICU, definitely I would be appearing in this exam, because it was I have 3-4 qualifications, but this exam actually I just tried to do it with the same preparation, but actually I failed by very narrow margin. But I tell you this, for the people who are just appearing in EDA exam is very easy, because there is no negative marking. In this exam, in European Diploma Intensive Care, I appeared in 2016 and I failed by 3%. The passing was 60 and I had 57. But actually it was very difficult for me, because they were giving CT scans and MRIs in which I am blank. I was not able to get the diagnosis. But for the people who are working in ICU, and by the way, this European Diploma Intensive Care also gives you, like if I'm not wrong, it is also in the list of GMC PLAB exemption categories. Okay, so there is some criteria. You must be working in ICU. You have some training paper, not even a specific training. If you have experience of ICU, they accept this thing. There is part 1 and part 2, and then like it's a good exam. So you can see by the scheme of this source, this is a whole bunk, like there is a bunch of this packed modules of almost every topic. So I would highly recommend you people, so whenever possible, you just, what's the problem? The problem is that you just majority of the people, they ask me this question and the counter argument that, sir, how to retain it, number one, and number two, sir, how to revise it. So thing is that if you, for example, if you are reading this thing just as a top up of from wherever you have read, and then you are finding some of the few things which you have not read before, you just extract them there and then and note it down in your book from which you are reading, and after that you will have no problem. Now my teacher with whom I used to study, I really miss him. I wish he were here. He will be making life hard for me, because I become confused whenever I'm talking to him. Even today, his name is Awais Tahir. He's working in Medina these days. But he used to sit down and use all the sources and extract whatever were important thing and note down on maybe sticky notes. You can make sticky notes and put it on the book, and then you will not lose this. His mechanism was like that. I used to pull out anything which I am needing it. I just used to get a printout and used to make folders of specific topics or specific units. So that was my revision. Because but unfortunately, because this is a concept which I am challenging you, that don't read books. Don't need to cram the books. You use the books to find the answers rather than reading like a novel. It's not true in 2022. If you are just because if you go to any hospital and you open the book, ask anyone, there will be highlighters everywhere. And I also had this concept, because I couldn't do this ever. And for the first time when I went for a 1-week course in UK for the FRCA preparation. It was a FRCA preparation course. I got failed in my FCI exam for the first time. And there I found that none of them had any so-called textbook which we are worshipping, majority of people, Morgan or problem oriented or this. They used to have, everyone used to had access to these articles. Everyone, majority of them used to have a tablet, okay, and because there is free access from their college, so they are using it. But I have made this same thing for you, and these articles you will find everything, but of course you will have to open and search a little bit. So if you just don't search it, you will not be able to gain the benefit. But I'm sorry, I'm distracted, but this is very important thing. Please try to make your habit that you are doing post graduation. You are not in class 5, that you will get a notes and you will read it and you will pass the exam and you will become a big doctor. No, even if you pass the exam without a correct concept, I repeat this request multiple times, that how will you justify yourself that you will not want any of your family member to be anesthetized by a person who does not have the clear concept? So why would you like to give anesthesia to someone's mother, father, sister, brother without a clear concept? And believe me, all other specialties maybe are in a different way, but anesthesia ICU is very dangerous. You are dealing with life or death. If you do something wrong, you will lose the life of the patient. So just try to understand this concept and try not to run from exerting a little more than you want. Okay, so sorry for just distracting, but this is my message, this is my request to all of you. Okay, and then when you will read from multiple sources, Tayyab, you will not get you confused, because if you are using only one source and they have written one thing, you will try to follow it, and maybe that thing is not correct. Okay, so that is how. Anyways, so I will come back to okay. So loss of relatively salt free, as I told you, that hyponatremia, we have, I think, discussed this thing just a second. Please, if you mute yourself, it is a distraction for me. So diabetes insipidus, in which water loss alone do not culminate in hyponatremia unless either they are very large, as in diabetes insipidus, or aggravated by decreased water intake, as occur, for example, if you have a patient who is mentally not oriented, so this problem will exaggerate, or babies who cannot drink water or tell that we are thirsty. Okay, so if these age group or these patients disoriented, dementia, or these patients will be at more risk of exaggerating this problem. Okay, so they told about this central brain death or neurotrauma or nephrogenic, in which there is lack of response of the kidneys. Either it is the brain or it is the ADH is there. And you know how to differentiate between nephrogenic and this one central or nephrogenic? How you differentiate? Anyone, please?
So we can give vasopressin to see if it is effective.
Yes.
Yes, please continue. Who was talking? Hasnan, please continue.
So if we can give a trial of vasopressin, so if this works and the urine output is reduced, so we would know that this was most probably central related and
Yes.
not nephrogenic.
Yes.
But if this does not work, it would be nephrogenic.
And to be very specific from exam point of view, you should be knowing the numbers or percentage, how much improvement occurs with the use of desmopressin or this vasopressin. Where actually desmopressin is a better choice. Why? What is difference between vasopressin and desmopressin? Anyone knows? Usman? Yes.
I think route of administration. Because of route of
No. Actually, desmopressin it will not cause increase in blood pressure because it does not cause vasoconstriction. It has almost all the effects of ADH, but it does not cause vasoconstriction because vasopressin or ADH via this it can cause vasoconstriction as well. Not agreed. Okay. In acute hyponatremia, plasma hypertonicity shifts fluid from within the cell to extracellular space, causing brain shrinkage in acute hyponatremia. However, in chronic hyponatremia, again, because brain compensate by synthesizing idiogenic osmoles, bringing fluid back into the cells and reversing some of the brain shrinkage. This is the case of okay, so actually, I think I have said something which you don't digest. I'm talking so maybe I've used the word ADH. There's difference between vasopressin and desmopressin. Okay, because vasopressin is vasoconstrictor, has vasoconstrictor effect as well. So if I'm not wrong, just correct me if I'm telling wrong. Desmopressin will not cause hypertension because it will not cause. It will have all other effects. Like ADH like effect, but it will not cause increase in blood pressure. Okay. Okay. So principle of correction hyponatremia are similar to those of hyponatremia, and or etiology it is better. Then you will be calculating the plasma volume and plasma tonicity. So in hypovolemic patients with impaired hemodynamics, isotonic fluids to correct volume status. So this is something very confusing, that if you are correcting hyponatremia and if you are the patient is hypovolemic, so you need to give isotonic fluids, like you have to give normal saline initially. Okay, or you can give half, at least half. So you have to maintain the volume status first. Okay, then you will be able to correct it. Otherwise your efforts will not be in the correct direction. Okay, the recommended rate of correction of hyponatremia is 1 millimole per liter per hour, or not more than half the calculated free water deficit that we in the upstairs we calculated 7.5 liter. So you should not correct more than half of it. Okay, so what would be the fluid of choice for correcting hyponatremia in a diabetic patient presenting with blood glucose of 1100, serum sodium of 155, and a blood pressure of 70/50? Yes, this answer, please. Yes, Usman. Anyone wants to answer? Which fluid will you give in start? Okay, so this is finished. Sodium. Okay, any questions, please? So who have not listened to the previous discussions, I would suggest you to listen. Okay, so it will be easier for you to. I am going slow because this topic is even difficult for me to explain. So that's why I'm not rushing through it. So due apologies for that thing. So I will suggest you to have a look on this document. Majority of the things are repeated. You will find this in the main link. Okay, so when I will upload the document, I will I usually put the link of the this one, the Google Drive link. Okay, so this is also, we have almost done all these things. Okay, and NP. Okay, sir. Any questions, please, before we finish?
Sir, my question is, how do we assess the fluid status, intravascular volume status before classifying or hyponatremia? Do we assess clinically on basis
Of
of
course,
the on seeing
clinically and
dehydration,
blood
skin
levels.
turgor, or hemodynamics, or CVP stroke volume variation?
Yes, Mozama,
Um,
actually, I have discussed this thing before. I will just
yes, sir.
tell you that
Clinically.
the clinical, see A, B, C, we do like that. In all patients, the evaluation is on in the same way. If you are, for example, if you see the patient is tachypneic, patient is tachycardic, patient is not maintaining the airway, this is a sign which you will count it as a sign of decompensation. Am I right? With reference to even fluid status. Then blood pressure will be telling you something. Heart rate will be telling you something. Okay. Then this stroke volume variation will, if you have arterial line and you are monitoring this, you will find it through CVP. Okay. Then urine output will tell you something. Okay. Then the general hydration status will tell you something. Okay. So you will go step by step, and then the blood levels will be telling you. Okay, you will see the serum sodium, then you will have the osmolality. Okay, you will usually compare urine osmolality versus plasma osmolality. It will tell you something. Okay, so then clinical feature, clinical picture, clinical history will tell you a lot of things. Okay, so that is how we go. So we have covered almost all the aspects of hyponatremia. We will discuss tomorrow hypernatremia. Okay, so apologies, because actually, I don't get time to prepare. I just hardly go to the hospital, come back, take some rest, and here I am with you. Yes, Sayyam?
Sir, my question is, can we do this diploma in intensive care with?
I suppose yes. If you have the experience, I can share the eligibility. I will share. I will try to put it in this YouTube link. I will put it. Okay. So I will request you, any of you who are student, who the students. I am not the student. Now I am only trying to help you out. And I again apologize, because this is a topic in which I lack a lot. I have just, and because of my lack of experience in ICU recently, in last 6-7 years, I am out of ICU since I last worked in ICU in 2014, and only because I am in touch with the knowledge, so that's why I am. So if any of one of you can prepare this topic, you will find a lot of sources here. Okay, so it will be even help for me and help for everyone. In this link, you will, I have taken this. Yeah, please mute your mic, please. Okay, so I was just, again, I have lost the screen share, and did not tell me. So in this link, I share this link with you people. Okay, so you will find, even I have taken subscription of this slide share. So I found these presentations maybe which can help you. Okay, so if some of you can volunteer to prepare in a better way. Okay, because unfortunately I am not able to do it. I'm unable to do it. I don't get the time to do it, and I am not working in a teaching setup that I assign one of the resident to do it for me. So I can only request any of you volunteer, because this is, remember one thing, if you understand this topic, this will help you as a good doctor, This is at least this is, you can say this is the homeostasis. The homeostasis is the most important thing. Even in operation theater, you are doing the same thing. I listen from the people, anesthesia technicians, they are always attaching the normal saline to a patient with diabetes. And then I again have to tell that normal saline is not indicated, not needed, unless very specific conditions. In a normal patient, there is no indication to use normal saline, but unfortunately we are using it. Okay, so similarly, you will be able to understand how much fluid. Usually the majority of people, I can guarantee you, and in OR, majority of anesthetists don't give proper fluid. They are, majority of time they are giving less fluid. They are afraid patient will go in overload. Nothing will happen. The circulation time, if the kidneys are making urine, the patient heart is pumping. Even if you give more fluid, there is no problem at all. If you give less fluid, that's more problematic. But if you just, like for example, if you, even if you have a 10 kg baby and you have a deficit of this one 10 hours, so 10 multiplied by 10, and then around its maintenance is 40. So even for a 10 kg, 400 ml, so even you make it 500, so 500 ml is nothing, but nobody will be giving that much fluid. Okay, so 40 into 10 is 400, am I right? So 400 is deficit, but you will tell them they attach microburette. Okay, so then I tell them there is no need for microburette in a patient more than 10 kg. There is no need. 500, even if the patient receive 500 ml is nothing. Okay, so I'm just giving an example. 1 or 2 hour surgery, adult, no way you can give less than 2 liters, because around 1 liter will be only the deficit. But I can guarantee you that majority of people, they are afraid and they are not giving proper fluid. So and there are more problems with giving less fluid than giving slightly higher fluid in a patient with normal cardiac function. Nothing will happen. Okay, so this is a message. I'm going slowly for this topic, and I will inshallah make sure that all of you listen. If you have not listened, please start from the lecture 1, and then it will be easier for you, because a number of things are repeated, and you will come to know. At the end of the day, you should be that, like Mozama, you asked this question, you have to go clinically. You will be starting from clinical side, and then you will go forward. Okay, with the labs of urinary osmolality versus plasma osmolality, urinary sodium versus plasma sodium, clinical condition, volume status. Okay, and then you will and of course the clinical scenario in which the patient is there, and then you will reach the ultimate diagnosis and how to deal with it. Usually either it will be normal saline, either it will be some diuretics, for either normal for either it is hypernatremia or hyponatremia. Either it will be volume restriction, either it will be use of this normal saline, or 5% dextrose water in some scenario. Because just before I finish, can we give free water even in hypernatremia? Can we inject free water? And if we inject free water, what will happen?
Yes, sir.
Tayyab, please tell, because Dr. Humera, I need a hammer for you. I need to be very angry at you. Yes, Tayyab, please, anyone. If we give free water, what will happen?
Sir, oral we give.
Hemolysis of RBCs will
IV,
happen.
I'm talking. Yes, Mozama, this is the answer. If you are giving free water, NG, no, I'm not talking about NG. All of us drink water. This is free water. I'm talking about IV. Because if you give IV, it will cause RBC lysis, because the water will enter in the this one RBCs. So it will result in hemolysis. So that's why we don't give free water. Okay. So thank you very much. And thanks for your patience. I apologize. I'm not as fluent in this topic. So, but I'm trying hard. I'm learning with you people. Okay. So if any one of you who is listening, please, if you can read about it, so it will, even you will learn. So you ask the question and we will just try to find out the solution. Okay, thank you very much.